We have a visitor from Canada who at the last minute agreed to come down to fill in for a Canadian economist that had been invited to speak. Randall White, Dr. Randall White, is a clinical associate professor of psychiatry at the University of British Columbia and the medical director of the British Columbia Psychosis program. He has a lot of labels after his name, but what matters here is also he's a co-editor of E-Rounds, a quarterly synopsis of healthcare policy research published by Canadian Doctors for Medicare. That's an organization that has been formed of physicians to protect Canada's single-payer medical financing system from politicians who wish to do it harm, as well as even some in the physician community who would like to see the gloves come off so they can make more money. In fact, he's been a coordinator of the British Columbia chapter of Canadian Doctors for Medicare for 5 years, from 2007 to 2012. He's an advisor for the Seacouver Project of the American Medical Student Association, which introduces medical students to the Canadian healthcare system. A marvelous idea. I think that's really great. So, Dr. White.
Thank you, Sherry. So I want to qualify a little bit, with all due respect, something Representative McDermott said about the Canadian system. He was correct in that by about the early 1970s, it had spread all the way across the country, and every province adopted a single-payer system. So in effect, Canada has, if you include the territories, 13 independent sort of single-payer systems. But the capstone occurred in 1984 when Parliament of Canada passed a very important piece of legislation called the Canada Health Act. And I'll just read a paragraph from that because it shows how in Canada healthcare is considered a human right. It is hereby declared that the primary objective of Canadian healthcare policy is to protect, promote, and restore physical and mental well-being of residents of Canada and to facilitate reasonable access to health services without financial or other barriers. And the Canada Health Act put in place 5 principles for healthcare in Canada, which are quite important. They are universality, accessibility, comprehensiveness, portability, and public administration. And the public administration, I think, is a really crucial one right now, because that means that both the funding and how the funding flows in Canada and the delivery has to be not-for-profit and not investor-owned. So as a psychiatrist, I'm most familiar, of course, with mental health care. Why does investor-owned mental health care compromise the right to health care? As Ms. Schmidt was describing, all the details involved in determining how something can become considered a human right, and accessibility and quality are part of that. So a study from 2003 in a journal called Psychiatric Services, on the basis of data collected since 1980, found that nonprofit, in the United States, nonprofit psychiatric inpatient care had superior performance on access, quality, cost efficiency, and amount of charity care compared with for-profit provision of mental health care. A 2008 study, after controlling for patient hospital and other covariates, when compared with not-for-profit hospitals, public hospitals were more likely to admit severely mentally ill patients than investor-owned hospitals. And then something I find particularly shocking and illuminating, a 2011 study looked at the relationship between the size of jail populations and the private share of hospital psychiatric beds. And they found that a 1% growth in investor-owned, for-profit psychiatric beds led to a 2.3% annual growth in jail inmates. So a single-payer system, as we have in Canada, can help reduce inequality, but it cannot eliminate it. And inequality actually probably has greater effects on health than what we do as doctors and nurses, et cetera. And if you want to learn more about this, I encourage you to read a very, I think, important book called The Spirit Level by Richard Wilkinson and Kate Pickett. And even though we have single payer in Canada, we still have lots of inequality, and we have inequity even in healthcare. There was a study of family practice clinics in Toronto in which people called clinics as sham patients, either saying they were an executive looking for an appointment, or they were somebody on welfare looking for an appointment. The executive's odds of getting the appointment was 1 in 4, and the person on welfare's was 1 in 7. So even though the doctors would be paid the same to see those patients, there's still something else at play there. I feel very fortunate, though, to be practicing psychiatry in British Columbia. I no longer deal with third-party payers, carve-out benefits, myriad formularies, and justifying my treatment plan to various bureaucrats. I run a provincial program for people with severe psychosis that is publicly funded, free of charge to my patients, and comes with a research budget. The mean length of stay is 6 months. I know of nothing comparable in the United States. So keep up your efforts for universal health care. Here in the US, and we'll keep up our efforts to defend universal health care in Canada.